gentlemen, guess who's back again. Behind the Counter is back.
Tell a friend.
It has been quite a long time since we've done a Behind the Counter show episode, but here we are back again with HB Pharmacy and Gasper's Best. Today with my father, Johnny B. Good, the pharmacist and owner at HB Pharmacy, who's been here for like 80-something years now, it feels like. And we are here today to talk about an
feels like
interesting...
160, but that's okay.
Yeah, fair enough. We are here today to talk about some new interesting development, kind of an old, new interesting development.
Sure.
For things related to autoimmune diseases such as multiple sclerosis, rheumatoid arthritis, IBS. If any of these conditions are resonating with you, you may want to listen up because John, as a compounding pharmacist, has a pretty unique and new perspective on how some new age medicines are dealing with these sort of conditions. So John, thanks for joining us today.
Sure. I'm excited to talk about this topic today. And let me dial back first a little bit too, because I feel like, you know, our healthcare system, which many of us now call actually a sick care system, really doesn't. What happens is, you know, you don't go to the doctor until you present with something. You know, you have a condition. Maybe you have a cold or something else, or maybe, God forbid, you have a scan and you see something and they develop. So you develop something, and then you're going to go to the doctor. Maybe here's a prescription because this is what the standard of care is. We're going to do this. We're going to do these tests, and it's almost like you're just funneled into a system, and it's not a well care system or a health care system. It's a sick care system.
Right. Very reactive.
Right. It's very reactive, and it's not the way we should be. We need to be proactive in managing our health, and then we can, you know, stay well, and then maybe we can call it a healthcare system and not a sick care system. I think that part of that is trying to find root causes and in disease, right? And today I really want to talk about naltrexone. Naltrexone is old, but it's also new. It's not really discussed too widely because naltrexone lost its patent many years ago, and you know, pharma can't really patent it, so they're not going to dump a lot of money into research projects and promoting it, you know, so because there's not a lot of money in it. But
correct me if I'm wrong too. Naltrexone was originally used for opioid overdose, perhaps, is that right, or something related to opioids?
So actually, where it was used very well and very successfully is in still actually for alcoholism and also for to prevent. So people that were chronic alcohol users would get that to help them, you know, kind of stay off of the medication.
Sure.
Because it actually makes the alcohol not work. It also makes opioids not work. So your body doesn't react to it and get that euphoria that you're normally getting.
Got it. But now in the compounding world of pharmacy, which is customized medication, that we are a compounding pharmacy, for example, so it's a specialty niche of pharmacy where we actually customize medication for the individual patient for whatever the purpose may be.
Right.
You're saying that in low doses now, naltrexone is being used for all kinds of other purposes, specifically related to some conditions like, you know, rheumatoid arthritis, certain skin diseases, IBS, things of that nature, correct?
Yeah, absolutely correct. So, and again, it's not brand new that we're even doing low dose and ultra low dose naltrexone. In fact, there was a Dr. Bahari that in the 80s, when the AIDS epidemic was raging in the country, he had a lot of people that he was treating that were unfortunately also using opiates and also drinking too much, and they were already sick, so he was trying to control that, and so he was giving them naltrexone. And what happened was the cost of the tablets was so expensive, they actually started breaking these tablets apart to just try to make it last longer.
Interesting.
And he just had an epiphany one night and realized, gosh, there's some good things happening here. I noticed a lot of anti-inflammatory things going on. And let me look more at this. And so then he took a bunch of tablets. He went and talked to a compounding pharmacist. This is in the 80s, late 80s. And they made up a lower dose, maybe not as low as what we're talking about here today, but lower. And then they began using it and did some informal studies. And that's the genesis of where this all came from.
Kind of like how sildenafil, or not sildenafil, but Viagra was accidentally.
Sure,
right?
Because that was originally came out as a drug called Revatio. It was used for pulmonary hypertension. And this is all about off-label use, you know, and for sure, because naltrexone isn't, you know, in the literature isn't used for these other things that we're talking about today. But certainly, you know, just because of happenstance, much like with the sildenafil, they discovered, okay, this is also helping men with ED in addition to helping with the pulmonary hypertension.
Okay. So let's talk about some of the specific autoimmune conditions, right? Like how exactly, and this is a little bit, I'm probably still being researched and more information coming to light every day, I would imagine, but how exactly is this working to help with these autoimmune conditions?
Well, you have to dial back first to looking at, being sick, right? Sometimes being sick or getting some kinds of diseases is genetics for sure, but it's also, how we live our lives, right? So if we have too much sugar, for example, in our system, sugar drives the amount of insulin we have in our body. Insulin drives up inflammation. The more inflammation we have, the more you have chronic disease, right? So we are trying to promote using LDN or low dose naltrexone to put into the doctor's toolbox and the pharmacist's toolbox to help fight inflammation, because that is, again, we get back to root causes, which I mentioned a few minutes ago. We're trying to fight the root causes of disease. And inflammation is one of the starters of, because before you even ever see, God forbid, a cancer or a tumor, right? That might be the cells and the things that are going on that start that whole process. It could be years before that develops. That inflammation starts at a very small cellular level, and then eventually will develop into something down the road that's a disease. It doesn't happen right away. So, the things that we can that as people where we contribute in a negative way, not exercising enough, maybe weighing, not watching our body weight, not sleeping enough, making poor food choices. Again, eating healthy is very expensive and it's not easy to do, but people are now more than ever avoiding gluten, for example. Why? Because it causes a lot of inflammation in the body. So you don't have to be gluten sensitive or have conditions about that. It's just a good idea sometimes to avoid gluten. Then of course there's things like smoking and alcohol too, all adding inflammation too. So
okay. All right, excellent points. So we got to dial it back and kind of focus on our behaviors and our lifestyle choices and things like that before even getting into the medication, obviously, right? But okay, let's say we're working on some of those things. Those are obviously important. Where does LDN or low dose naltrexone fit in the mix then, in terms of all of this kind of stuff and how it interacts with autoimmune diseases and things of that nature?
Okay. Well, I mean, so you could say, well, basically you're saying, look, how is it going to help me? How's it going to work, right? So again, when you do it in a low dose, and so keep in mind, we're talking the doses we were talking about for the other conditions like the alcoholism and stuff were 50 to 100 milligram doses, sometimes more than once a day. So we're talking about now for low dose naltrexone somewhere between 0.5 milligrams or half a milligram up to 4.5 milligrams, give or take. So it's very, very low.
Low dose indeed.
Yeah, very low. And then there's even something else we could talk about another time called ultra low. But for the purposes of today, we're just going to stick to this. So what happens is, it's a little bit complicated how it all works, but it actually ends up increasing your levels of your endorphins, and so that, which is something that is a positive thing. It also can help increase your level of dopamine, and it causes indirectly through all these different reactions within the body decrease in inflammation. So when we're trying to fight inflammation through all these other different chronic conditions we could talk about, inflammation is kind of a root cause of a lot of disease. So when you're stopping the inflammation, you're stopping the progression of the disease. Or if you're already have an ongoing disease, you can perhaps correct it or at least dial it back.
Sure.
I mean, we have a lot of different disease states or conditions that people are treating, that are seen. The biggest one that initially started was multiple sclerosis, and but there are many other things: IBS, Crohn's, Colitis. There are skin conditions like psoriasis, Vitiligo.
And you're saying that part of the cause, or what's exacerbating these conditions, is inflammation related.
Right. On a very, very microscopic level, it all starts there. So, reversing it there at the root cause is better sometimes than, some of the current treatments that are out there. And I'm not saying that actually you should not try some of put it this way, if you've gone through, you're getting treated for psoriasis, or you're going, God forbid, you have multiple sclerosis, or some of these other conditions, or even triple negative breast cancer. I'm not saying you shouldn't look at what the standards of care are and try to pursue those types of things. But as an added tool while you're trying to get well, you should put this on board as well, because this is a really amazing tool. It really can work to help improve your condition. We're just seeing that more and more. And you got to understand that this started in the initially in the 80s, right, when they did this, but there's, on PubMed, which is a reliable source of information in the medical literature, there are over 1,500 articles now.
Oh, wow. I didn't realize that.
It's and this has been going on where they actually have done a lot of studies since the early 2000s.
Sure.
So today it's 2024. It's not like we're doing groundbreaking news story here, but at the same time, it takes a long time for things to become mainstream. Yeah. And this is something I think that needs to become more mainstream. People need to take naltrexone and use that as a tool. Doctors, nurse practitioners, PAs, et cetera, need to keep that in mind.
So if it's well reviewed and well sourced, and obviously not mainstream yet, but still something that only a specialty pharmacy can do, who are then, and of course, part of the wellness, triumvirate, if you will, is patient, provider, physician, and then pharmacist in this case, right? So there's a team of people working on this.
Sure.
If there's a specialty pharmacy in the know and a patient in the know, then who are the types of physicians who are familiar with this sort of therapy beyond just the standard of care toolkit that you referenced earlier?
Well, so sometimes people are like, well, what kind of doctors do I have to go to get
right,
this?
Exactly.
Right, exactly, right? But the truth is, any physician could write this prescription. The doctor needs to learn about it and know about it. And part of what my goal was today in discussing this with you is that to tell you that if you have a doctor that's receptive to a discussion, I'm more than happy to call them.
Sure.
I'm more than happy to forward them several articles from PubMed. We have some great research articles out of Brown University, Dartmouth. There's a lot of very credible sources out there to just help guide them to decide whether they feel it's appropriate for that patient.
Sure. Okay. So then, if that's the case, what are some good next steps that you would recommend for patients here? Like, obviously, you can send patients more information as be a resource in your own front. You can be a resource for the providers, but what would you recommend patients to do, especially for something that's a little bit new and maybe they're hesitant to kind of explore their options with?
Well, I guess the first steps are to
educate yourself, I suppose.
Educate you, exactly. Sure. Educate yourself. Educate sometimes your practitioner. The other side of it is if your doctor or nurse, a practitioner, or physician assistant doesn't want to explore this, we have contacts, here through HB Pharmacy where we can direct you to a provider who is well versed in prescribing low-dose naltrexone. I think it's important, but it's not necessary to go to one of these practitioners. But if you run into a dead end with your practitioner, call me, and I'll happily refer you to a practitioner that will be glad to help you.
Sure. Not to get on a soapbox here for a sec as well, but, we were alluding earlier to the sick care system instead of the healthcare system, which I thought was kind of funny. But related to that, more and more these days, I've seen that our system almost requires patients to be the primary advocate for themselves, right? If a patient, needs to drive the information and drive the care and treatment they're receiving and almost not just accept any answer. I'm not saying go to 80 million doctors and pay 80 million co-pays to do whatever and explore, but you kind of have to be an advocate for yourself in a lot of different areas, especially with things that are maybe not necessarily on the standard of care path where someone's just going to write a script next type thing,
No, I think that's very true. And I think that some of that's, the system itself, and then sometimes it's insurance company driven because they're not going to pay for these things because it's not part of the normal thing. So they'll only send you through the normal funnel of how to handle that. This is how we're handling that. But that's a big problem. But I think that the other things, getting back to your question, is that people need to understand if they're going to start this, they need to be patient.
Sure. No pun intended.
Yeah, that's right. Patients need to be patient. But seriously, all kidding aside, many people, they could be on this 3 to 6 months before they start seeing.
Oh, wow. Okay, that's good to know.
So it's an investment in time. And a lot of people, they'll do it for 6 months, and then they'll say to me, you know what, I don't think this is working, because they're not happy. Let's say they're doing it for psoriasis, and the skin is only, moderately improving. Sometimes for that type of thing, we'll do a cream instead of an oral compound. But they'll comment to me afterwards, you know what? After I stopped, I didn't realize how much it was helping me.
Sure.
So it's a very interesting.
subtle
that's how subtly this works. So that's why it's almost like some people are taking it just to enhance it right now. I have several physicians that are taking this right now that don't even have an autoimmune disease. They're just taking a real low dose to just fight the chronic inflammation that goes on in our body, almost as a preventative thing to prevent some kind of problem from happening and developing.
Now, we wouldn't be doing our due diligence as a pharmacy, even though I'm not a pharmacist, you are, but as a pharmacist, there has to be some kind of side effects or potential negative outcomes? Is there anything like that that you've seen or heard of from your experience?
Well, I mean, I think that that's another. So this is so it's funny because a lot of times now one thing that really bugs me about the side effects and stuff. If you looked at all this direct-to-consumer advertising that you see on television,
side effects may include.
There's a long list, and they say it fast, and it sounds awful, right? And a lot of these things that they're doing for some of these autoimmune diseases, even are kind of harmful, and it can actually cause disease themselves.
Sure.
With this drug, has been tried and true. It's tested. Is it 1,000% safe? No, but it's the side effects are minimal. I mean, maybe some sleep disturbance.
Okay.
Sometimes some digestive issues. Sometimes vivid dreams. But they're very, very mild. What I'm saying to you, it's worth a shot if you've gone through the normal routine of trying to manage whatever condition you're trying to manage, and you're not getting better. You ought to consider this because there's no downside to it. There really isn't any downside. You have to have some patience. You have to make sure that the doctor understands, especially a new prescriber, that it's critical to taper. You have to start with a low dose of maybe a 0.5 milligram and then maybe go up to the 0.5. A lot of doctors who understand and appreciate that naltrexone, how it works on the receptors in our body, just jump up to 4.5 or 5, and that's too much. You need to find the right dose, you need to what's called titrate up.
Sure.
So that, over a month or 2 months, that's what we do. We use these kits to just get the person up to the proper dose. And everybody's proper dose isn't the same. Some people stay at 3.5 milligrams. Some go up to 4.5 milligrams. But it's important to limit the side effects and the downsides by taking your time and getting to the right dose. Beyond those other minor side effects, though, and making sure that you're patient with getting to your right dose, there aren't any really downsides. You have literally nothing to lose. It's generally not covered by most insurance plans, but so people should know that up front. But I mean, our new patients, when they're starting a starter kit, I think they're paying somewhere around $40 a month for a kit. Once you're on a regular dose, if you're staying on this long term, for a couple of years, for example, you get a 3-month supply, and it's it's less than $100 for a 3-month supply.
Gotcha.
Maybe, so you're really not, so if you're thinking at that $30 a month for something that's going to do all this good, it's sometimes less than what your copay is when you come in and have to pay for a medicine. You're paying more than $30 for a copay for some drugs.
One thing I like about what you said too, which is really how our healthcare system should be, is you're talking about an educated physician and a pharmacist working together to find a specific dose for that specific patient. We're really looking at this on a patient-by-patient basis instead of just like, everyone's on this dose, everyone's on this, here you go.
It's just not a cookie-cutter thing.
Exactly.
And that's not what good healthcare is about. That's not what good compounding is about. And, as a pharmacist, you're 100% right. We want to work directly with the patient, get the feedback from the patient, work very closely with their practitioner, and to make sure that this person's at the right dose. And again, then we just need patience, which is easier said than done, because when you're not feeling well,
very good point.
you really need to, somebody telling you to be patient is not, you don't really want to hear that.
Right.
But like I said, we have some children now that are on the spectrum, right? And you've tried everything, and now we're using topical naltrexone because sometimes it's hard to give autistic children medications, and we're putting it in a transdermal cream and giving these children, and it's making a difference. And so it's all part of the toolbox. It's not to say that naltrexone should be the only thing people use, but it needs to be considered, and right up there with all the other treatments to attack these kinds of problems.
Sure, great. Well, thanks for all that. Is there anything else you'd like to add before we wrap up here in another informative, albeit haven't done one in a while, episode of Behind the Counter?
Yeah, sorry we've been absent. We'll be back some more. But no, I just want to encourage people to reach out, and we're going to provide some information and some links on this video, so to show you some of the different conditions this is used to treat. But that's by no means a completely comprehensive list. There are some articles there on from PubMed, and a little story about Dr. Bahari as well. So please check those out, and by all means, please call me, and I'd like to personally discuss with you how LDN could help you. John from HB Pharmacy, 201-997 2010. I look forward to speaking with you.
Awesome. Thanks a lot, John/Dad. And also, those links that John mentioned are going to be on the YouTube video. So if you're not checking this out on YouTube, you can always go to hbpharmacy.com. You can call the number that John just mentioned. That's the pharmacy number. Or you can also email pharmacist@hbpharmacy.com. Pharmacist, spelled like pharmacist, at hbpharmacy.com. And you can get in touch with John or one of our other pharmacists that way too. We'll be happy to share any articles and answer any questions that way. Other than that, thanks everyone for joining and listening to us as always, and we'll see you on the next one.